Hello, everyone. My name is Tyler Patron. I'm a second-year medical toxicology fellow here at Emory University and the Georgia Poison Center Medical Toxicology Fellowship. I'm going to start off by telling you all about an extremely unusual case we had about a year ago and use that as a jumping-off point to talk about lead toxicity from retained bullet fragments in general. This is a part of International Lead Poisoning Prevention Week. These are my disclosures. These thoughts are mine and mine alone and do not reflect the views of the United States government, armed forces, or any other government entity. So here are our objectives for the day. By the end of the lecture, we hope you can recognize lead toxicity in a patient with retained ballistic fragments, discuss treatment strategies, and debate the utility of CSF and blood lead levels in the management of suspected lead encephalopathy. So we'll start with the case. We have a 27-year-old paraplegic male, secondary to multiple gunshot wounds from retained ballistic fragments in his left parieto-occipital lobe and T12 vertebral body, presenting to the emergency department with headaches and hematuria. His original trauma occurred 7 weeks prior. He saw that his nephew was getting into a confrontation and went to break up the fight. In doing so, he stepped between his nephew and his fellow combatant when the other party allegedly pulled out a 9mm weapon and opened fire, striking the patient multiple times. After several weeks in the hospital, he was discharged home, about 3 weeks prior to this presentation. From a functional standpoint, he was paraplegic, but could independently move himself in his wheelchair and had full use and mobility of his upper arms and had no other significant neurological deficits. He was completely able to perform his ADLs. 2 days prior to this presentation, he started complaining of a headache, blurred vision, and pain when moving his eyes. In addition, the morning of his presentation to the hospital, the patient had begun developing hematuria, which is significant as he does straight cath himself for urine. These slides are representative images of both a CT angiography and MRI. The retained ballistic fragments are shown with the blue arrows here. You could see an MRI of his spine on the left, highlighting the retained bullet in T12, as well as the center image and the image on the right, highlighting retained bullet fragments within his left occipital and parietal regions. So during his initial presentation, you can see that his vital signs were pretty unremarkable. His neuroexam was largely unchanged from previous, other than his dilated pupils. A right homonymous hemianopia was noted, but was present prior to this admission. CBC and CMP were unremarkable, and a urinalysis showed proteinuria, bacteriuria, pyuria, and a positive leukocyte esterase. You can see here the relevant diagnostic information. As I mentioned, his positive UA. He had a negative CT scan and an unremarkable lumbar puncture, other than an opening pressure of 29. So on hospital day 1, the patient was admitted and started on broad-spectrum antibiotics for the presumptive treatment of urosepsis. He continues to complain of blurry vision. By hospital day 5, the patient has continued to decline. He has now developed waxing and waning mental status changes and is completely blind. He was on meropenem with infectious disease following, and ophthalmology was reconsulted in the hospital and confirmed he had no light perception. No ophthalmologic causes could be found. Initial urine culture grew out Pseudomonas that was sensitive to meropenem. On hospital day 8, he continued to decline. A stroke alert was activated for increased lethargy and left upper extremity weakness. Repeat imaging shows new leptomeningeal enhancement and lesions in the cervical spinal cord with diffuse signal abnormality of his T-spine. From hospital day 9 to 21, the patient continues to have waxing and waning mental status changes and neurological symptoms with unremarkable workups from neurology, neurosurgery, ophthalmology, and internal medicine. He is on IV meropenem and amphotericin with clear repeat urine cultures and clean blood cultures ×2. He will intermittently hallucinate, remains blind, and is unable to follow commands. He claims that there are cartoon people in the room occasionally and that he is actively getting into a car accident and will scream uncontrollably in the room. So 21 days in and running out of options, the team turned to a light in the darkness when all other lights go out a toxicology consult. The following labs were ordered and tested negative before evaluation by the toxicology team. As you can see, he had a very extensive neurological workup, including autoimmune antibody panels, an NMO spectrum evaluation, lumbar puncture cytology, antihistone and anti-centromere, as well as ANA screens and double-stranded DNA. From an infectious standpoint, again, a similarly broad workup. He, including a negative HIV, RPR, toxoplasmosis, Listeria, West Nile, CMV, HHV6, and then, as I mentioned before, 2 negative blood cultures and 2 negative lumbar punctures as well, where white blood cells were seen but no organisms could be identified. And from a toxicological standpoint, he had a negative urine drug screen, acetaminophen, salicylate, and ethanol. Other consultants had weighed in at this point in his hospitalization. Infectious disease said this remains a difficult diagnosis with no clear culture growth to guide therapy and with progressive worsening of the neurologic exam and imaging despite very broad coverage. Neurology notes his repeat imaging was remarkable for new leptomeningeal enhancements with lesions in the cervical spinal cord with diffuse signal abnormality of the T-spine. Concern continues to be for an infectious process causing the worsening lesions of within his spine, but the patient is on broad-spectrum coverage with meropenem and amphotericin. Ophthalmology states that a month later, from their prior evaluation, he has rapid progression of vision loss from 20/20 to no light perception, which is unlikely related to raised intracranial pressure given his only mild elevated opening pressure and would not escalate ophthalmologic therapies at this time. When we evaluated him on hospital day 22, the patient was acutely delirious, responding to internal stimuli, and completely unable to follow commands. Per his wife, during his periods of alertness, he is completely unable to move his right arm, but can make a fist with his left hand. His vital signs, as you can see, were notable for a tachycardia, but otherwise pretty unremarkable. He did remain completely blind on our exam. He had no blink to threat, and his labs were notable for a mild microcytic anemia. So a blood lead level was obtained at this time, and over the weekend resulted at 38.6 micrograms per deciliter. Normally, if you say this in a conference room full of toxicologists, this would produce a lot of shock gasps and clutch pearls and someone fainting from shock, because this is not a very high level, and certainly not a level near with which we would expect someone with lead encephalopathy to be. So we did elect to start the patient on Suxamer, and his sensorium cleared. He became ANO times 3 over the course of 4 days, although he would still have intermittent periods of confusion. He gradually began to regain strength in his upper extremities, and his vision improved to the point where he was able to make out colors and shapes. CSF lead was undetectable when tested. Post 3-week chelation blood lead level was 5 micrograms per deciliter. Surgical pathology of his leptomeningeal lesions reported back nonspecific perivascular inflammation. In rehab, the patient was making a good recovery, able to utilize a wheelchair, and had documented 4 out of 5 upper extremity strength. I think it can be hotly debated whether his course of Suxamer and his clinical improvement were causally related, but now I'm going to transition to discuss retained ballistic fragments and lead toxicity in general. So when we are looking at retained ballistic fragments in general, and we're looking at toxicologic studies, we really don't have a lot of good, high-quality evidence, as with most things in toxicology. We don't have case control series or cohort studies or randomized control trials. We really just have expert opinions, case series, and case reports like this one, and then we combine all of those together into systematic reviews. So there are 120,000 firearm injuries in the United States every year. But at this point, we still don't have a lot of clear evidence as to what the prevalence of lead toxicity is from people with retained bullet fragments. In general, if you have a retained bullet fragment that's just in soft tissue, it is much less likely to cause systemic toxicity versus a retained ballistic fragment that has contact with bodily fluid, specifically like synovial fluid if it's in a joint space or something like this. Other things that could matter are the bullet characteristics. If there's a presence of fractures, obviously that's going to make it more likely for there to be worsening systemic toxicity, what the metabolic state of the person is, and the presentation of these could be rather insidious. You could have people who present long after their initial trauma with abdominal pain or this microcytic anemia or maybe these neurological findings.
So for testing, in addition to getting a whole blood lead level, other useful things to consider would be a CBC to evaluate for the microcytic anemia or basophilic stippling that you can see on microscopy, a zinc protoferrin, a UA, as well as a CT or an X-ray to look at the actual ballistic fragments themselves. For treatment strategy, surgical removal is going to be key if it is anatomically viable. Otherwise, chelation could provide some benefit, although it should be noted that chelation only reduces the total body lead burden by about 1 to 2% per round of chelation.
Going back to our specific patient, in terms of retained ballistic fragments within the CNS, it's really limited to case reports. There's not a whole lot of good data. So there was a separate patient who was a 23-year-old man with new abdominal cramping, diarrhea, and mood swings, along with some paresthesias, that had a blood lead level that went up to 10. And then after his retained bullet fragments were removed, his blood lead level only went down to 7.5, but his symptoms improved and he was better. Anatomically, it is difficult to remove retained ballistic fragments within the CNS for obvious anatomical reasons. What's interesting in our case is this clinical improvement after chelation despite a negative lead CSF. So we looked a little bit more into lead CSF as to if this is something that is clinically useful. So you'll note there's a running theme here in terms of these studies, and that there's really limited evidence looking at specifically CSF studies for CNS retained ballistic fragments, really case reports and some case series. One lab noted they're reporting them as 0.5 micrograms per deciliter. There's an ALS study that looked at lead within the cerebral spinal fluid and found that it was detectable. You know, obviously, if you're getting a lumbar puncture in these patients that have these traumatic brain injuries from retained ballistic fragments, there's a concern for herniation. And there's really no evidence that CSF lead levels should be used to guide chelation or management. It's really unclear the relationship between blood lead levels when the source is within the CNS.
So in terms of what to do when you have a patient like this in the outpatient setting and how often you should be getting blood lead levels, as long as lead is in contact with body fluids like a synovial joint or something like this, you should be checking a blood lead level. Although there's no need to measure levels 1 year after injury unless the patient becomes symptomatic. You could get blood lead levels about every 2 weeks after the injury, followed by monthly for 3 months post-injury, and then annually. And then you can be followed annually with an annual blood lead level in an outpatient setting. In terms of removing the bullet itself, the limitations of surgical removal are going to primarily be anatomic, obviously. The initial surgical management outlined here by the European trauma guidelines state that you should really try and remove a ballistic fragment immediately if it's intra-articular within a vessel lumen in the CSF itself, or if it's impinging a nerve, again, if this is anatomically feasible. And then delayed surgical management could lead to lead toxicity or a rising blood lead level.
For chelation, as I mentioned earlier, chelation really only minimally reduces the total body lead burden, about 1 to 2%, anywhere up to 5% in some sources. There's limited evidence for long-term benefits, and there's a risk of chelating essential elements that are not lead, that you will also risk chelating when you start somebody on something like Suxmer. There is the cost and affordability of the medication. Some potential cutoffs that have been suggested for adults is greater than 70 micrograms per deciliter, and for children greater than 45 micrograms per deciliter. So for take-home messages, if a patient has symptomatic lead toxicity and significantly rising blood lead levels, you should
consider removing a retained ballistic fragment if it is anatomically feasible, and you could consider it, but it's not an absolute if it has contact with body fluids, and consider the timing of the injury if this is something the patient had for a long time versus if this is acute. Consider the diagnosis of lead toxicity in patients with the following symptoms and a history of retained ballistic fragments. So if they have weight loss, GI complaints, anemia, or any kind of unexplained neurological findings. Thank you all so much for listening and tuning in. I hope you enjoyed.